I would like to start off by telling you two stories. The first story is about Michael, who is a 29 years old engineer who presented to the ED with a rash after starting a new medication a week prior. He was initially triaged as a CTAS-4 and waited for 9 hours in the ED. No one knew what to make of this rash. I would like you to take a second and think about what would be your differential diagnosis for this rash. As you can see in the picture, dusky patches and raised atypical targets on the chest. Michael ultimately was diagnosed with Stevens-Johnson syndrome that progressed to toxic epidermal necrolysis during his admission. Stevens-Johnson syndrome is a rare, severe drug reaction that is characterized by mucosal erosions with skin pain and detachment, most commonly triggered by medications. Initial lesions are flat, atypical target lesions, and dusky red macules of varying shapes and sizes, similar to Michael's rash in the previous slide, which can resemble erythema multiforme. In contrast to erythema multiforme, Stevens-Johnson lesions evolve rapidly into large erythematous areas with bullae formation and epidermal necrosis. Often, the eruption is widespread with the predominance of the lesions on the trunk. This is a condition with a 25% mortality. Early recognition and diagnosis is imperative to decrease the mortality rate in these patients. The second story is about a patient that I saw in the emergency department. This was her third visit to the ED for the same complaint. She presented with a rash that looks like this. As you can see on the left picture, some scaly plaques with scaling on the frontal scalp. On the right, you can see well-demarcated papules and plaques with overlying whitish scale. During her previous two ED encounters, she was diagnosed with a fungal infection and treated accordingly. Despite the antifungal treatment, her symptoms got worse. Obviously, like many of our patients, she doesn't have a family doctor. She presented again to the ED and waited for 10 hours. Because her diagnosis was delayed, her condition got worse, and she developed more lesions, as you can see here. Eventually, she was referred to the Skin of Color Dermatology Clinic. She was diagnosed and treated for psoriasis. This patient inspired me to do this talk. She made me realize that we're not trained to identify rashes, especially in patients of color. Hi, everyone. Welcome to my grand rounds. My name is Mejbel. I'm a PGY3 emergency medicine resident at the Ottawa Hospital, and today I'm very excited to talk to you about pigment, perception, and rash decision, dermatology, and skin of color. My supervisor for this talk is Dr. Shabazz Sayed, and my goal today is to train your eyes to see disease on dark skin. The objectives of this talk are the following: to give you an overview and history of dermatology and skin of color, to highlight the need for cultural competence in dermatology, to give you an overview of the Fitzpatrick scale for various skin tones, and to recognize common ED rashes in skin of color. As the largest organ in the human body, the skin frequently manifests early signs of various diseases, serving as a pivotal clue in the diagnostic process. Think of Lyme disease, for example, a truly devastating multi-system disease with various systemic complications that can be treated early when we recognize the classical rash of erythema migrans. Skin diseases are the fourth most common cause of disease, affecting almost 33% of the world's population. By 2042, more than 50% of the US population will have skin of color. Locally here in Ottawa, 26% of our residents are people with skin of color. By 2040, 1 in 4 Canadians will have been born in Asia or Africa. Given these statistics and future projections, I believe it's our duty as ED physicians to increase our commitment to providing inclusive care in the emergency department. We will be seeing more patients of color in the ED, and this is why I chose this topic for my grand rounds. Let's make things better, one step at a time, to providing a more inclusive care in the emergency department. Without any doubt, there is a race gap in dermatology. Dermatology as a clinical specialty emerged in Europe in the 19th and 20th century. Historically, skin conditions were described in patients with lighter skin. As we all know, dermatology as a specialty relies on pattern recognition. During medical training, we are mostly trained to diagnose rashes on light skin complexions. Given the differences in how rashes present in skin of color, this means patients with dark skin are often undiagnosed or misdiagnosed, resulting in delay seeking appropriate treatment. In 2013, a survey among 78 dermatology trainees and junior consultants in the UK showed that only 49% of them thought that they were competent in ethnic dermatology. What is ethnic dermatology? It's basically an area of interest dedicated to the presentation, diagnosis, and management of skin disorder in patients who have pigmented skin. In a US survey, 47% of dermatologists and dermatology residents reported that their training was insufficient in skin condition in patients of color. In another survey, among 56 dermatologists in Ireland, 46% of these dermatologists did not feel confident in diagnosing skin conditions in patients of color. 46%. Let that sink in. These were consultant dermatologists. Their job is to look at rashes every day. Can you imagine how the average emergency medicine consultant feel about diagnosing rashes, let alone rashes in skin of color? In the survey that I have sent last week, I received 51 responses from our resident and staff group. Thank you to everyone who filled it. Not surprisingly, it seems that everyone struggled with diagnosing skin conditions in patients of color. Almost everyone thought that we did not receive sufficient training to be able to diagnose conditions in patients with dark complexions. There is only one person who answered yes, which I think probably by mistake, or could it be Dr. Nate Murray? In the context of dermatology, why does race affect the medical care you receive? Probably because of lack in training healthcare specialists. I mean, look at the surveys I've shared with you earlier. Most dermatologists don't feel competent in ethnic dermatology. There is a safety issue for patients with dark skin tone, as healthcare professionals lack clinical confidence in managing and treating all ethnicities equally. It has been shown that patients of color are widely underrepresented in dermatology. The majority of photographs available in dermatology textbooks continue to be of light-skinned patients. For example, a review of current dermatology textbooks used in residency training revealed that only 4.5% of images were in skin of color. Only 4.5%. I mean, if we look at the survey about locally our residents in skin of color, there were 26%. Another example of this race gap is at the undergraduate level. A Canadian study analyzed more than 4,000 images from physical exam, history taking, and anatomy textbook that are used in medical school. 4% of these images were in dark skin tone. How do dermatologists describe different skin tones? In 1975, Fitzpatrick scale was developed by American dermatologist Thomas Fitzpatrick as a way to estimate the response of different types of skin to UV light, the level of tanning versus burning of an individual's skin response to UV exposure. The scale has 6 different types. This is the language that dermatologists use to describe different skin tones. Type 1, light, pale white, always burns, never tans. Type 2, white, usually burns, tans with difficulty. Type 3, medium white to olive, sometimes mild burn, gradually tans to olive. Type 4, olive, moderate brown, rarely burns, tans to a moderate brown. Type 5, brown, dark brown, very rarely burns, and tans very easily. Type 6, black, very dark brown to black, never burns, tans very easily. And remember, this does not include people who use gear and talk about common dermatological conditions that we encounter in the ED. Atopic dermatitis or eczema, a very commonly encountered skin condition in the ED, affecting 36% of the pediatric population and up to 23% of the adult population globally. Eczema is triggered by cold weather. A lot of immigrants with skin of color don't realize that they have eczema until they experience a real Canadian winter, eh? The way atopic dermatitis appear in people with darker skin tones has distinct characteristics. One significant aspect is the challenge in identifying erythema, a key sign of skin inflammation. I am confident that a lot of us here would be able to diagnose eczema in light skin. This is how we were taught to recognize atopic dermatitis. It looks like this. You can see on the left erythematous plaques with excoriations over the forearm and hand on the left side, and on the right you can see widespread scaly red plaques. But how does eczema present in skin of color? Erythema in eczema usually is more prominent in skin types 1 to 3. But what does erythema look like in darker skin tones? In individuals with darker skin, the stages of eczema show varying hyperpigmentation levels. Erythema in dark skin may appear dark brown or violaceous instead of pink. The typical erythematous and scaly lesions of eczema may appear as lesions with a grayish, violaceous, or dark brown hue. In darker skin, erythema may be subtle and often overlooked. Sometimes gentle pressure to blanch the areas of involvement may help reveal subtle erythema. The picture on the right shows scaly, violaceous plaques on the thigh. Both of these patients were diagnosed with eczema. You can appreciate how vastly different eczema presents in dark skin. It is important to recognize the subtle erythema in darker skin so that the severity of eczema is not underestimated. This is a comparison of eczema in infants with darkly pigmented versus lightly pigmented skin. You can appreciate how the same condition can appear significantly different on darker skin. In eczema, dry skin sometimes may have a whitish or ashy color appearance. Thickened, hard areas typically appear hyperpigmented. You can always ask the patient if they notice any change in their skin color. On the left, you can appreciate how eczema can present with scaly purple plaques, and on the right is an example of chronic eczema with post-inflammatory hyper and hypopigmentation. Follicular prominence is a characteristic presentation of atopic dermatitis in patients of African descent. It is rarely seen in type 1 to 3 skin. In lighter skin colors, follicular papules appear skin-colored or erythematous, as you can see on the picture on the left. In darker skin color, erythema may be subtle. Papules may appear purple or brown, as you can see on the right. This image was in the quiz that I have sent last week. I asked you about the most likely diagnosis. Let's see how our group did. Only 16% of the group was able to identify the correct diagnosis. Not surprisingly, as personally throughout my medical training, I was never taught on how eczema may present differently in dark skin. Eczema in skin of color can present like this. You can see on the left thick papules and plaques on the neck, and on the right you can appreciate hard papules and post-inflammatory hyperpigmentation on the lower back of a patient. Pigmentary changes are more prominent in darker skin tones and include post-inflammatory hypo, and/or depigmentation. Normally, eczema resolves with pigmentary changes lasting from weeks to months. These pigmentation can cause a lot of social distress to patients. This is why early recognition and treatment of eczema are crucial to reduce or prevent long-term pigment abnormalities. Periorbital hyperpigmentation occurs more frequently in eczema patients with darker skin tone. The patient on the left has periorbital eczema with scaly hyperpigmented plaques on the upper and lower eyelid. The patient on the right has a large post-inflammatory patch on the forehead and cheek. Sometimes patchy to diffuse hyperpigmentation may be a sign of active disease, like in this patient. This is another example of diffuse hyperpigmentation in a patient with active atopic dermatitis. In this patient who has eczema, you can appreciate the gray, purple, erythematous patches with hard, thickened skin. The increased blood flow of erythema does not always present red or pink in dark skin, as you can see here. If you only look for redness, you may miss the diagnosis of eczema or underestimate the disease severity. Let's summarize the nuances of eczema and skin of color. First, erythema may be subtle and often overlooked. Don't look for redness. Look for dark, brown, grayish, or purple discoloration instead. You can always ask the patient if they notice any subtle changes in their skin. Follicular prominence is a characteristic presentation of eczema in patients of African descent. Periorbital eczema is more common in patients of color, and post-inflammatory pigmentary changes are more prominent in dark skin and can cause a lot of social distress to patients. This is a picture of a critical diagnosis that we make in the ED every day. Cellulitis is a common bacterial infection of the skin that presents with erythema, pain, warmth, and swelling. Don't forget to page the HiDoc study, or otherwise you may get an angry messages from Dr. Yadav. We all know the importance of diagnosing cellulitis early to prevent devastating complications. These are pictures of two patients diagnosed with cellulitis. In darker skin, you can see how erythema can be very subtle. On the left, erythema is easily appreciated, and on the right, erythema present as purple discoloration. Sometimes using a bright light may help spot any subtle changes, any subtle color changes in the patient's skin. The presence of tenderness and cobblestoning and pocus may provide additional diagnostic information. You can see here, both of these patients were diagnosed with cellulitis. Bullous impetigo is a bacterial skin caused by Staph aureus, resulting in the formation of large blisters known as bullae. On the left, you can see the classic presentation that we are taught in medical school with honey-colored crust on the chin. In dark skin, you don't see the classic honey-colored crust appearance. Crust may appear gray, purple, or dark brown. This is another example of impetigo. You can notice how the crust appearance differ from patients of lighter skin. You can appreciate the grayish, purple, and sometimes dark brown discoloration. Lyme disease is endemic in the Ottawa Valley and not an uncommon presentation in the emergency department. This is a rash that we train to recognize during our medical education journey. Erythema migrans can appear as a hallmark bullseye or target-shaped lesion. One of the earliest physical exam findings to appreciate in Lyme disease. We know that Lyme disease can lead to devastating systemic complications. I mean, just look at what happened to Shania Twain, for example. That's why early diagnosis and treatment can affect patients' morbidity. One study of patients with Lyme disease found that there was a higher proportion of diagnosis of arthritis, which is the late-stage Lyme disease, and a lower proportion of diagnosis of erythema migrans, which is the earliest stage of Lyme disease, among Black patients than among white patients. This is probably because erythema migrans present differently in dark skin, and we were not taught on how to recognize it. The red color of erythema migrans is more readily appreciated in lighter skin colors. In darker skin, it's difficult to appreciate erythema, or sometimes it may appear deep red, purple, or brown. These two patients with different skin tones have the same diagnosis of erythema migrans. On the left, you can see an annular patch with a central light brown color and surrounding reddish rim on the skin. On the right, there is an expanding lesion without center clearing on the back of a knee. This can be a very challenging diagnosis to make. It's probably a diagnosis that we miss more frequently in our patients of color. I think the first step for us as ED physicians is to be aware of how erythema migrans may present differently in dark skin and not fixate on the classical presentation that we were taught in medical school. When I looked for pictures of this rash in 4 different dermatology textbooks and on the internet, I was only able to find 3 pictures of erythema migrans in patients of color. That's probably why we were missing the bullseye. When I asked Dr. Samantha Bismengo, a dermatology resident at University of Montreal, about tips on how to recognize erythema in patients of color, she replied, for erythema and skin of color, you can look for that classically described violaceous hue that is sometimes only evident by the trained eye. Otherwise, relying on other clinical signs of inflammation helps, such as warmth, swelling, and tenderness to palpation. Also, sometimes asking the patient, do you find your skin is more red or has changed color, can help. Patients are experts of their own skin. Psoriasis is a chronic, intermittently relapsing inflammatory disease characterized by sharply demarcated erythematous silvery scaly plaques, most often seen on the scalp, elbows, and knees. Virtually any site can be involved. Emergency medicine physicians are trained to recognize the classic presentation of psoriasis, as seen in this patient with a psoriatic lesion on the knee. There are different subtypes of psoriasis, which is outside the scope of this talk. In the next few slides, I will go through how psoriasis may present in skin of color. The primary lesion in psoriasis in patients with lighter skin is a red scaling papule that further develops into a red scaling plaque with sharply demarcated borders. In dark skin, there is less conspicuous erythema and lesions may appear violaceous or hyperpigmented. You can see on the right, you can appreciate the hyperpigmented plaques with overlying silvery scale and post-inflammatory hyperpigmented lesions on the legs. Both of these patients have psoriasis. You can appreciate with lighter skin, the lesions are looks more like pink or red plaques with silver white scale. And in patients with darker skin, the papules and plaques are violaceous with gray scale, as seen on the picture on the right. More examples of how psoriasis may present in dark skin. The patient on the left has well-demarcated, scaly purple plaque on the earlobe. On the right, you can appreciate well-demarcated plaques with overlying silvery scale on the posterior neck. It is crucial for us to recognize and be aware of the substantial differences in the presentation of psoriasis in skin of color. More example of psoriasis, you can see on the left there is a large, well-demarcated scaly lesion, and on the right you can see a scaly plaque with erythema on the arm. Psoriasis is often misdiagnosed in Black women. In the quiz that I have sent last week, I included this picture and asked you about the most likely diagnosis. Let's see how you guys did. Most people thought that this was a fungal infection. Only 2 people out of the 51 responses answered correctly. Psoriasis in skin of color is frequently misdiagnosed as a fungal infection. Black women may present with more severe scalp psoriasis. Both of these patients were initially misdiagnosed as a fungal infection. There is a diagnostic delay for Black patients with psoriasis, likely because of the educational gap in medical training. Delaying such a diagnosis can bring a lot of social and psychological distress to the patient. Here we can appreciate the violaceous scaly plaques on the upper back on the left and the thick, scaly, well-demarcated plaques on the dorsal hand. In Black skin, the redness and silvery scale of psoriasis are not usually seen. Black individuals often have more extensive cutaneous involvement than white individuals. Both of these patients were diagnosed with psoriasis. On the left, you can appreciate a well-demarcated lesion with hyperpigmentation, and on the right, you can appreciate large, pinkish, and hyperpigmented plaques covering most of the trunk. Let's summarize the impact of skin color on clinical presentation of psoriasis. Again, erythema is subtle. Plaques may appear pink, purple, grayish, or dark brown. Post-inflammatory hyperpigmentation is an issue that occurs with greater frequency and severity and tends to persist longer in darker skin. Dark skin patients usually have more extensive cutaneous involvement, and Black women may present with severe scalp psoriasis that is often misdiagnosed as a fungal infection. If you see a patient of color in the ED and you think that they may have psoriasis, they should be referred to the Skin of Color Dermatology Clinic at the Ottawa Hospital. I will talk about the referral process at the end of this presentation. Dr. Ratish Bose, who is the founder of the Ottawa Hospital Skin of Color Dermatology Clinic, says it's important that we recognize the subtle signs of cutaneous inflammation in patients of color, so we don't underestimate the severity of the condition, especially in atopic dermatitis. In his clinic, the conditions that are incorrectly diagnosed that may present at very severe stages include atopic dermatitis and psoriasis. He made a comment on the cultural sensitivity in patients of color, the apprehension about seeking medical care, and significant lack of access to appropriate color. Since we are likely to see these patients in the ED, it is on us to try to be better at diagnosing rashes in darker and darker skin to help these patients. Keloids are dense, fibrous tissue nodules typically found at areas of previously traumatized skin or arising spontaneously on normal skin. Lesions may be single or multiple. Over weeks to months, these large nodules become painful, tender, itchy, and grow to become very large. They can cause chronic discomfort, be disfiguring, and restrict normal tissue motion. Most patients start developing keloids in their 20s. Keloid disease is a significant clinical problem for patients of color. Although keloids are clinically benign, they can behave in an aggressive manner and are often psychologically and socially devastating for patients. Here you can see two examples of keloid. You can appreciate how disfiguring they can be. A distinction should be made between a keloid and a hypertrophic scar. All trauma that involve the dermis will heal with a scar. However, in certain individuals, the scar is much larger and thicker than what's considered normal. These lesions are called hypertrophic scar. In contrast to keloids, hypertrophic scars are always preceded by trauma and are always confined to the margin of the wounds, as seen in the patient on the left. Hypertrophic scars also appear immediately after trauma and show a tendency to gradually regress over time, whereas keloids can be delayed in appearance and very rarely spontaneously resolve. How do we differentiate keloids versus hypertrophic scars? Keloids very rarely regress and are not confined to the margin of trauma. Keloids are resistant to therapy. Growth of keloids sometimes can be accompanied by itchy, burning sensation. Keloids often develop months after wound repair, unlike hypertrophic scar, which develop within weeks after cutaneous injury. Patients with keloids or hypertrophic scars should be referred to the Skin of Color Dermatology Clinic. How do we counsel patients with keloids in the ED? Tell them to avoid tattoos, to withhold ear piercing or any elective cosmetic surgery. And if these patients present to the ED with a laceration, it is important to minimize, in order to minimize and prevent keloids, it's important that we do not put too much tension during laceration repair. Another condition that presents in skin of color, pseudofolliculitis barbae, aka shaving bumps, is a common dermatological disorder of the hair follicles affecting people of color who shave. It frequently occurs among population where naturally curly hair is common. The close shaving of curly hair causes the hair to penetrate the wall of the follicle and extend into the dermis as it grows back or curve back on itself and pierces the skin, such as with an ingrown hair. The condition is more common among Black men. On the left, you see perifollicular papules and pustules in the beard area, and on the right, you see multiple inflammatory papules confined to the beard area. The primary lesions of these conditions are papules and pustules in the beard area that can cause cosmetic disfigurement, including scarring, post-inflammatory hyperpigmentation, secondary infection, and keloid formation. These papules may appear red, purple, gray, or different shades of brown. These patients should be referred to dermatology. How do you counsel these patients? The only 100% effective preventative treatment is to discontinue shaving. When you see these patients in the ED, tell them to stop shaving and refer them to dermatology. Because once they develop scars or hyperpigmentation, the skin does not return to normal. Cutaneous eruptions are one of the most common signs of adverse drug reaction. Drug reactions are estimated to occur with a prevalence of 2 to 3% in hospitalized patients and 1 in every 1,000 patients has a serious cutaneous drug eruption. Reactions may range from common xanthomatous eruptions to life-threatening conditions and may be limited to the skin or have multi-organ system involvement. In patients with darker skin, clinical findings may be subtle and more difficult to diagnose. Mild erythematous or maculopapular eruptions are often underappreciated in richly pigmented skin. Morbilliform drug eruption is the most common of all medication-induced drug rashes. It consists of red macules and papules that often arise on the trunk and spread symmetrically to involve the proximal extremities, as you can see in the patient on the left. Pruritus is a common feature. In patients with darker skin, redness may be difficult to visualize, with erythema manifesting as a purplish discoloration, as seen in the patient on the right. Onset is usually 4 to 14 days after initiating a medication. The time to eruption may be shorter if the patient had previously been sensitized to the triggering medication. The eruption may happen even if the medication has already been discontinued. The eruption, it's most commonly seen with the use of antibiotics, such as penicillin and sulfa drugs, allopurinol and phenytoin. You can see widespread erythematous papules and plaques on the back of a patient on the left. In darker skin colors, post-inflammatory hyper or hypopigmentation may be more prominent and may take weeks to months to resolve. On the right is a patient with a resolving morbilliform drug eruption showing hyperpigmented papules and plaques on the back. Always ask the patient if they notice a change in their skin. History is important here, especially medication history, up to 6 months prior to presentation, and associated symptoms such as pruritus.
We are presently working on the phonetic tube system. Thank you.
Physical exam must include all skin, oral, genital, ocular, and lymph nodes. These two patients have the same diagnosis. You can see how on the left it's easier to appreciate erythema, and on the right there's a subtle patchy erythema on the arm of a patient with dark skin. Another condition that we may encounter in the ED is drug-induced hypersensitivity syndrome, which is a potentially severe drug reaction with systemic manifestation, including fever, rash, and internal organ involvement, most commonly hepatitis. The acronym DRESS for drug reaction with eosinophilia and systemic symptoms was proposed as a more specific term in the 90s. However, because only 60 to 70% of these patients demonstrate eosinophilia, many have suggested to using hypersensitivity syndrome to avoid confusion. The most commonly implicated drug groups causing this syndrome include anticonvulsant, sulfonamides, and NSAIDs. Clinically, symptoms develop 2 to 8 weeks after initiation of the responsible drug. If a patient is re-challenged with a drug, the reaction might occur within 24 hours. An xanthomatous eruption is present in over 80% of cases and can worsen even after the withdrawal of the offending drug. Same diagnosis, different skin tones. On the left, you can appreciate the diffuse erythema on the arm of a patient with hypersensitivity syndrome from an antibiotic. And on the right, you can see very subtle erythema and superimposed papules. If you suspect your patient may have drug-induced hypersensitivity syndrome, full examination of the skin and oral mucosa is important, and blood work, including LFTs, to rule out internal organ involvement. Hidradenitis suppurativa, or acne inversa, is a chronic, destructive inflammatory disorder of the terminal follicular epithelium. Usually, it manifests as a chronic, recurrent inflammatory nodules, abscesses, scarring, and/or fistulas that are incredibly painful. HS is thought to be more prevalent in individuals of African descent. And HS patients report greatly decreased quality of life, and it should be recognized that this disease has not only physical, but also social and emotional ramification. HS is seen most commonly on the buttocks, breast, groin, and axilla. In light skin, it usually presents with pustules, erythematous nodules, and linear scarring, as seen in the axilla of the patient on the left. In darker skin, erythema of papules, nodules, and cysts can be difficult to discern, and these lesions may appear dark brown, purple, or gray. Usually, a range of procedures and medical intervention is often necessary over time to achieve optimal control. When appropriate, encourage weight loss in patients who are overweight and smoking cessation. While these changes do not typically lead to disease resolution, they may lead to reduced disease activity and progression over time. Because of the severity of the disease and the foul odor of the drainage, social isolation and depression are commonly seen in these patients. HS patients have increased rate of suicide. In the ED, we should treat their pain, be aware of the social factors, and refer them to mental health support services when indicated. These patients should be referred to dermatology. In 2022, a new skin of color dermatology clinic opened at the Ottawa Hospital. This is the absolute best health experience I've had in Canada since arriving here 20 years ago, said a patient who attends the clinic. To refer patients, you can do this through Epic by ordering dermatology referral on the Dispo tab and choose the Skin of Color Clinic tab. Enter the details about the consult and sign the order. In general, Skin of Color dermatology encompasses skin phototypes 3 to 6. Alternatively, if you're working outside the Ottawa Hospital, you can fill and fax the referral form, which I will email to the group later today. I understand that recently dermatology have been rejecting a lot of referrers from the ED. When I asked Dr. Bose, he said that the Skin of Color clinic is less restrictive with referrals compared to the general dermatology clinic because the volumes are lower. Take home points. You don't know what you don't know. I hope I was able to train your eye to see disease on dark skin. Erythema is not always red. If you only look for redness, you will miss it. Instead, look for purple, dark brown, or sometimes grayish discoloration. Patients are experts of their own skin. Ask them if they notice any change in their skin color. Stevens-Johnson syndrome may resemble erythema multiforme and can be challenging to distinguish clinically, so keep it in your differential. Follicular prominence is a characteristic presentation of eczema in patients of African descent. Black women with psoriasis are more likely to have severe scalp involvement and often misdiagnosed. And lastly, don't miss the bullseye and be aware that erythema migrans present differently in patients with dark skin. I want to give a quick plug for 2 resources that can be used to enhance your pattern recognition for rashes in patients of color. Skin Deep is led by an international medical education team. It's a free, open access bank of high-quality images of medical conditions in a range of skin tone, with the goal to improve education and recognition of conditions in all skin tones, reducing inequalities and improving patient care. Mind the Gap is a handbook of clinical signs in black and brown skin that can be downloaded for free on their website.